This panel is called It's Not All in Our Heads. We're going to be talking about some of the depression, anxiety, irritability, and insomnia in perimenopause and menopause. But before we start, we're going to demonstrate how it's not all in your heads, it's also in your body. And we're going to do some mind-body work. And I'm going to give you the gift that you already have. You just don't always utilize it. So what I want you to do is I want you to close your eyes, no peeking, and take a deep breath in through your nose. Through your nose slowly. Hold it, and then out through your mouth. And one more time, but this time when you do it, think about those tense neck muscles and relax them as well. So in again, and out through your mouth. You can open your eyes. We just demonstrated the mind-body connection. And breathing is something we all do, but some of us hold our breath so tight, and we do a lot of chest breathing. We don't do diaphragmatic breathing. But if we just take the moment to validate how we feel and to acknowledge our feelings and to process these feelings, we can just have better moments every day. And so I'm going to introduce the wonderful panel that we have today. This panel will unpack why we struggle with mental health issues, things like sleep, things like brain fog, irritability, anxiety, and they're really going to help us to explain this, but we're also going to get really useful tools. So make sure you take your notes and again, share with others when you return home. So first, I'm going to introduce Dr. Kingsberg, Dr. Sheryl Kingsberg, and you'll see their long bios in your folders, but she's a clinical psychologist and professor of reproductive biology, psychiatry, and urology at Case Western Reserve University, and division chief of behavioral medicine in OBGYN at Cleveland Medical Center. Good to see you.
Thank you.
And Dr. Maki, Dr. Pauline Maki is the professor of psychiatry, psychology, and obstetrics and gynecology, and the director of the Women's Mental Health Research Program at the University of Illinois at Chicago. And Dr. Maki just came back from DC after, advocating for women's health, so thank you.
Yep, pleasure to be here.
Please have a seat. Okay, so before we start, I really just want to understand what your key takeaways are. What are the most important things that we should be focusing on during this panel? And we could start with you, Dr. Maki.
Sure. From my perspective, the main message that we have about mental health in the perimenopause is that if you happen to be a woman who has a history of major depression, and who has more major depression, men or women? Women, right? So as we go into the perimenopause, we're going to have more women with this history. The majority of those women will have a recurrence of their depression during the perimenopause. 58% will have that recurrence. So that means that for those women, it's really important to monitor your mental health, to have active discussions with your care provider, and to have strategies to plan around this elevated risk. And the idea is that if you have that history of depression, it's a recurrence, right? It's not a new thing. It's a recurrence. So it's the love the one you're with idea. Whatever worked for you for your condition prior to the perimenopause will work again in the perimenopause. So that's the group of women at increased risk, primarily.
Always hard to follow, Dr. Maki. I want to talk about the range of mood symptoms, that it isn't just depression, and depression isn't just depression. So we look at mild, moderate, and severe, and we look at anxiety. When we think of, for example, about postpartum depression, anybody in here have a postpartum depression? We think about two flavors of postpartum depression. We think about anxious, and we think about flat. And the same thing is true with menopause. There are many women who will have panic attacks. We learned about that before. And there are many women who are going to develop depressive symptoms. And unfortunately, if you go to your women's health provider, a gynecologist, sometimes primary care, they often dismiss it. We're trying to get it out of it's not just in your head. Or they'll tell you to go on a nice tropical vacation or just relax. And while breathing and mindfulness exercises can help, and look, I'm a cognitive behavioral psychologist. I do CBT for a living, and it is very helpful, but sometimes it's not enough. And we look at the biopsychosocial nature of menopause and menopause symptoms. And with that are the mood disorders. And so sometimes cognitive behavioral therapy will be enough, and sometimes pharmacotherapy will be enough, and sometimes hormones will be enough. And what's interesting, as we've been talking a lot about hormone therapy, we've been talking and how really valuable it is, but with premenstrual dysphoric disorder, with postpartum depression, and with menopause-related mood disorders, even though they are hormonally driven, the hormones are not always going to be the treatment. So not only psychotherapy, but sometimes you do need those antidepressants and other CNS drugs to address what is a hormonally based condition. So you need somebody who knows what they're doing and who is willing to listen, and please do not stop at that person if they say, oh, it's all in your head, just relax, it'll go away.
And Dr. Kingsberg, before we go to those treatments, how important is it to figure out which factors are causing the specific symptoms? Because sometimes it's confusing when you have a lot of symptoms at once.
Well, keeping in mind that biopsychosocial nature, which also helps you determine where you're going to go for treatment. If you're having anxiety, it's always helpful to start with somebody who knows how to treat anxiety. And by the way, panic attacks, which are very common, are different than anxiety in a real condition. And can I please use you as an example,
Sure.
Dr. Maki? So Dr. Maki was in a plane last night where the engine blew up. And she was anxious. That is not a panic attack. Right? A panic attack and sitting up in front of you and going blank because my postmenopausal brain, right? Could that be a panic attack? Maybe. Or could that be real anxiety because I've got a whole bunch of people staring at me? But panic really is when your body signals that it's in danger, right? It's a fight or flight response kind of thing. And if there's no bus about to hit you, or a saber-toothed tiger, which is where this comes from, that fight or flight, about to eat you, and I am going on safari in June, so that, again, would be not a panic attack. But without those, we have smaller things that trigger anxiety. And so those are the things that we can manage, and we can manage it in a variety of ways. It is always helpful to go to the provider you think is the one you trust, and you and that person together can decide, do I need psychotherapy? Do I need pharmacotherapy?
And you said biopsychosocial. That's something a lot of us learn in medical school, but I think it's really useful for non-medical graduates to understand those three buckets. Can you please just go into that a little further?
Sure. The biology would be the hormonal and neurochemical milieu that creates the physiology of those symptoms. But there's also psychological factors that contribute to how we interpret those physical symptoms. So, and what's going on in our lives? Do we have depression? Are we struggling with relationship issues? And then we have sociocultural factors. What our society tells us should be what we are also impacts, how we react and what our mood symptoms might be. So biology, psychological factors, and sociocultural factors and interpersonal factors all contribute, because how we relate to our family, our partners, if we have one, all can impact those mood symptoms. And that's how we look to see, I do a lot of sexual medicine, so that's and they kicked me off the panel. But did I say that? But when somebody comes in and says, I have no desire, for example, Sometimes it is biologically based. We've talked about low libido as one of the conditions, and so for that we would look at the biology of it. But sometimes it's depression related. One of the major symptoms of depression is loss of sexual desire. It's loss of all things of interest. Sometimes it's our religious and cultural values that lead us to not want to be sexual. It's shameful, it's guilty. And sometimes it's our partner, right? You could have all the drive in the world, but if you don't like your spouse, you're not going to want to sleep with that person. So that's how we tease out what treatment approach we're going to look at, right? We want to look at, does it seem to be more biologically based? Because I'll see women will come in and say, everything in my relationship is great. We're shared values, everything's great, but I don't have that drive anymore. I've lost that biologic urge. And I have other women who'll come in and say, yeah, I have drive, I masturbate, but I don't really like to have sex with my partner. And so that makes it very easy for you and your practitioner to decide which direction of treatment you're going to go. That's what I mean by biopsychosocial.
Beautiful, thank you. And so we're looking at this slide, windows of vulnerability. Dr. Maki, can you please just take us through this slide and help us to understand what that means?
So we know that women have about twice the risk of major depressive disorder compared to men. They're also at elevated risk for anxiety. This vulnerability actually comes online at puberty. So one of my absolute favorite studies, because I think it's so elegant, is a study by a researcher, Monica Ernst. And what she did is she followed boys and girls as they went through puberty, and she said, what changes as they age and what changes as they go through puberty? And she looked at the way that the brain gets wired. Not surprising, the way that the girls' brains got wired differed from the ways that the boys' brains got wired, in that the girls' brains became more self-referential. What does that mean? When our moods are low, what do? We talk to ourselves, right? We have negative self-thought. I'm no good, that person did something, nobody will ever love me, this is never gonna work out. And it turns out that it's the inflection of estrogen and progesterone at that time that causes that circuitry to get into gear, okay? And the extent to which these girls showed this self-referential circuitry predicted who was gonna get depression. Because the more that circuitry got ingrained, the higher the girl's risks for depression. So what does that tell us? It tells us that these hormones affect the wiring of our brains. And that especially when those hormonal levels are changing, that's what our brains don't like. They don't like the change in hormones. It's not the level. It's the variability in estrogen and progesterone that the female brain doesn't like. It wants it to be completely flat. Okay, so that's the theory, okay? So what does that mean? When do our hormones change? Puberty, when else? Pregnancy, and when else? Menopause, right? Exactly. So you can get women who have this predisposition for self-referential thought, and when their hormones become variable, this kicks in. Now, is this all women? Do all women get postpartum depression? No. Do we know that it's hormonally driven? Yes, right? Same thing with perimenopause. Some women are going to be vulnerable to that hormonal influence on their brains because of the way that the brain is wired. But that's not a universal. That's not everybody's brains, and we know that from postpartum depression. So that's kind of the theory about why our brains become vulnerable at these time points. And there's this beautiful literature that shows they actually measured estrogen levels every day for 8 weeks in women. And they said, what predicts how irritable she is during the perimenopause, what predicts her anxiety, and what predicts her depression. And it was the women who had the most variability in their hormones during the perimenopause. So, what does hormone therapy do? It flattens that out. What do oral contraceptives do? It flattens it out. So for women whose depression and anxiety is driven by that variability, going on one of those therapies should help, because you've dealt with the trigger, the thing that's making their thoughts self-referential. If going on that therapy doesn't help, then was it the estrogen? No. So then we go with an antidepressant. But the first line is typically an antidepressant. Now, it's not just those variability factors that influence our brains at these points in time. It's the other stuff that comes along with variable hormones. What's that? How many are sleep deprived? I'm sleep deprived. Yeah, what's your mood like when you're sleep deprived? Are you peppy and somebody cuts you off in traffic and you're like, oh, go ahead. That's fantastic. No, please, be my guest. No, we're punchy. We're punchy, and what happens when we're sleep deprived is that our prefrontal cortex fails to put the brakes on our amygdala. When your friend says something nasty, or maybe not a frenemy, says something nasty, and you're like, no, I'm not going to react. You know, I'm going to go to that happy place. That's your prefrontal cortex saying to your amygdala, stamp down. No, we're not going to go there. Those areas work in concert when we've slept well. But when we haven't slept well, they don't talk to each other. And that's why we get irritable. So the sleep deprivation is a main factor. What causes sleep deprivation in the perimenopause? Hot flashes. So my dear friend and colleague, Rebecca Thurston, discovered that 70% of the time that you have a hot flash when you're sleeping, you wake up. So the hot flashes can trigger these awakenings, right? So if your sleep is disturbed because of the hot flashes, that hormonal variability is going to be a particular trigger for you, right? So you have to treat whatever it is that's causing the sleep, because when we haven't slept well, night after night after night after night, we're going to get punchy and we're going to get depressed. And you don't need a PhD in cognitive neuroscience to tell you that.
Can I also add, though, that even women who have mild vasomotor symptoms may still have sleep problems.
Yes.
So while hot flashes will wake you up, so will other things in perimenopause. And so sleep is or insomnia is a very common symptom. And so don't think that you're crazy if you're not having a hot flash and still waking up.
Yeah, in fact, most of the times that you wake up in the perimenopause and the postmenopause, it's not triggered by a hot flash. So your waking after sleep onset is exactly that. It's part of what we go through, unfortunately.
And your explanation was so helpful while having that visual, because many of us are visual learners. So seeing you talking about the fluctuations and then showing the visual of the hormones, that really helps to solidify the information. So help us to understand some of the other neurobiology behind some of the symptoms that we experience, Dr. Kingsberg.
You're asking me to explain Dr. Maki's experiences. I'm going to let her take over and talk about neurobiology.
So in the brain, our estrogen, so we have estrogen receptor alpha and beta, 2 types, why not? Okay, and they're located right next to our serotonergic receptors. And when things in the brain are located next to one another, there's a reason. They tend to function together. And so estrogen does this dance with serotonin. So what do the treatments for depression do? They increase our serotonin, right? Estrogen also increases our serotonin. So there's this nice dance between hormones and brain chemicals that are critical to our depression. Okay? But there's something else really special about being female chemically, and that is progesterone. So how many of you have heard about the new treatment for postpartum depression, that pill, right? First time there's a pill for postpartum depression, and it works within 15 days. And the thing that it does is it gives us more of a breakdown product of progesterone. So our bodies metabolize hormones. They have what are called metabolites. One of those is something called allopregnanolone. And if I were to give you allopregnanolone, you'd feel kind of like what you did when you breathed. There'd be this nice calm, but you might get a little sleepy. It's elevated in pregnancy as well. So progesterone plays a role as well And that breakdown product of progesterone plays a critical role in our moods as well. So it's estrogen, it's progesterone, and it's the brain chemicals that work in concert with those two that really influence our mental health in the perimenopause.
Can I also add sleep?
Yeah.
When postpartum depression, the first treatment of choice is sleep, if they can get it.
Yeah.
Because how I describe it is whether you're going to use the new drugs or you're going to use SSRIs, if you don't have sleep, to me, it's like taking the medicine, pouring it into a bucket with a hole in it. And so that sleep sort of allows the use of those chemicals in the brain.
So before we go to treatments, how important is it to figure out which factors are causing the specific symptoms?
Sometimes it's not always that important to know exactly what. What you need to do is to be able to describe the symptoms because you need somebody to help you figure out where you want to go with the treatments. First of all, it's never going to hurt to have cognitive behavior therapy. It really doesn't hurt. And it is often an adjunct, even if it's not going to be the only treatment, it is often a very helpful treatment. What people worry about is that you'll be in therapy too long before you get to a medical treatment or a pharmacologic treatment. And trust me, a good cognitive behavior therapist knows when it's not enough. So if I see somebody I get referred I work in an OBGYN department. So my colleagues are referring patients all the time, whether it's for postpartum depression or PMDD or menopause-related mood disorders, and I know very quickly that cognitive behavior therapy isn't going to be quite enough to address their symptoms. At that point, shared decision-making. This is not just me telling her. It is shared decision-making to say, I really think a pharmacologic option might be helpful. And then it becomes, do we do hormones or do we go to an antidepressant? Some of it is her choice, and some of it is, getting a sense of whether it's the fluctuations that Dr. Maki was talking about that makes sense, like in perimenopause, which is the time, I've learned from the best, that it really is only in perimenopause that you can use hormones as a potential antidepressant, right? Because once they've settled out, postmenopausally, it will not help. But some women really will respond to hormone therapy to address their depressive symptoms. And that's a fair thing to try. And the antidepressants can also be used as well. So you have some options there. And it really is individualized. It is not a one-size-fits-all. So it's about you and shared decision-making.
May I add a neuroscience perspective on what Dr. Kingsberg just said? So do you remember how I said the prefrontal cortex puts your brake on your amygdala? If you do a brain imaging scan of people before and after CBT, do you want to know what you see? The prefrontal cortex puts the brakes on the amygdala more. It's not talk therapy without some kind of brain change. The reason CBT works is because it changes your brain wiring, just like a pharmacotherapy treatment will, right? So thoughts are powerful things. And if you get the brightest people, and I'm not just saying it because she's next to me, the brightest people I know do CBT. You have to be really, really smart to do CBT. And when you get a good CBT therapist, they will help you rewire your brain, help you think differently about your thoughts. And it's a powerful biological tool.
I'm glad we're spending so much time on sleep because sleep, like breathing, is free. We all do it, whether we want to or not, right? How many of us used to brag about pulling all-nighters and we wore it like a badge, and now sleep is so sacred. And sleep is important because with poor sleep, you have poor mood, you have worsened anxiety, you have poor health issues, you have poor thinking, right? It's hard to concentrate. So we're gonna spend some more time in this area on sleep. So Dr. Maki, what are some of the main sleep issues that we need to be thinking about?
Wakefulness after sleep onset, otherwise known as WASO, increases in the perimenopause. So what does that mean? It simply means, I really wish I was sleeping, but I'm awake. That's what it means. That's the sleep symptom that women report and that we measure using fancy polysomnography and actigraphy. So we measure sleep objectively because we want to think that we know what's going on in our bodies, but we don't always really know how well we slept. So in our research studies, we use these objective tools. And when you follow women from the time they're premenopausal to peri to post, you see this increase in wakefulness after sleep onset, and it actually persists into the postmenopause. It's one of those symptoms that for many women doesn't get better. And we know that from large longitudinal studies. There are other aspects of sleep that can get worse, but the frequency of those symptoms is lower. That includes things like not being able to fall asleep, right? And there's this kind of special mixture of the special storm that happens in the perimenopause. So let's think about the last time we woke up when we wanted to be sleeping. Okay, got there? Did you go to La La Land? No, you started ruminating, right? You started thinking about everything you needed to do. You go into this negative thought process as well, and unfortunately, the hormone variability puts us there more. So it's this perfect storm of waking up and then ruminating. And that's kind of a special thing about the perimenopause. And I'm sure Dr. Kingsberg will be much better than I ever could in talking about CBT for insomnia and how that's a particularly special tool in kind of taking away that cycle of sleep deprivation.
And Dr. Maki, there's also, people who have higher risks of sleep apnea, and that's
Yes.
one thing we don't think about
That's
as
right.
we get older.
That's right.
Is a part of it contributed from sleep apnea.
Absolutely right. So we run a longitudinal study called Ms. Brain, cool name, right? Ms. Brain, and we have women wear our objective sleep monitors, but they also wear sleep apnea monitors. And I would say 50% of the women that we detected in had no idea that they had sleep apnea. And you know what happens with sleep apnea is our oxygen gets cut off. And so it's really not particularly good for cognition. So I'm so glad you brought it up because this is a modifiable risk factor for our brain health, which we want to optimize at midlife so that we take the healthiest brains we can into our later years. So let's treat that sleep apnea and treat the sleep deprivation.
Thank you.
So how many of you share Wordle with a friend? Do you have a little, right? So my friends know when I have WISO because Lisa's on my little group thing. And so at 2 o'clock in the morning, when I wake up, and one of my ways of managing the rumination is to do something distracting. In the old days, it used to be a crossword puzzle because you can do a crossword puzzle and not have to finish it. You don't want to read a good book. You don't want to watch TV. You don't want to do something that's going to engage you. You want something that will shut down those ruminations. So sometimes I will give people a homework assignment of taking a pad of paper and dumping, it's a data dump, take all of those ruminations, which I got to remember to do this and don't forget to do this. If you put it on the paper, put it on the back on the bed, you're good. But mine is to do Wordle, because it takes just a couple minutes, because I can usually do it in 2. You said I was smart. And then I send it off. And then they'll say, why aren't you on hormones, Sheryl? Or what, are you not getting good sleep? Because 2 a.m. is when that happens. So just a comment.
And you feel really good about yourself, too.
That's right. Yes, if you can get it in 2 at 2 a.m., that's impressive. But CBTI really is very helpful. It is evidence-based, and cognitive behavior therapy is evidence-based. And to Dr. Maki's point, it really is about taking negative thoughts, beliefs, feelings, and behaviors, and working. It's a collaborative approach. It's not just passive. You and the therapist work together. Not because I'm lazy, but it works better when you work together and you alter those negative thoughts and you shift them. So for example, if you're panicking, what if I have a hot flash in the middle of a board meeting? that can create its own stress. And we know about thermoneutral zone, right, which is one of the reasons we have hot flashes is because thanks to that loss of estrogen, our thermoneutral zone of what our body senses as a good temperature changes, it narrows. And so if we go above that, the body says, whoa, we need to sweat you so that you can shiver and cool the body down. And so your stress level can also narrow that. So it's a double whammy. So if you're now worried about having hot flashes, you can actually help that along. And so it is how you manage the thoughts, the what ifs. Anxiety has a lot of what ifs to it. Even if you don't literally put a what if to it, it's about what ifs. And it's not what if I win the lottery. It's always in the negative direction. And it's usually catastrophic. And it makes sense. We as women tend to prepare for things. And it's an insurance policy. If we can create a what if that is the worst case scenario, our belief is it is an insurance policy to prevent how that will impact us. If I think about the worst and every possible negative scenario, then I'm ready for it. The trouble is you have now zapped all of your energy in that preparation, and it's always going to be something else that happens, not that 1 in 100 things that you'd thought of. And it doesn't help to have prepared for it anyway. It's not going to make you able to handle it better, and it won't hurt less if you get some bad news. It just zaps you when you're busy ruminating. So part of cognitive behavior therapy is to actually do the math, figure out whether it makes sense to have those negative thoughts, and if not, to find ways to alter them to more neutral and positive ones, to give you back control over your life.
And can we just take a step back and explain to everyone what cognitive behavioral therapy is? Because we brought this slide on, and there are different therapies on there, but we're really singling out CBT, cognitive behavioral therapy, because it's so practical. You could do it anywhere, and it is so powerful. It's something that when you learn and you practice, it can be with you for a lifetime. So can you please just take us through what the basics are?
Sure. Well, like I said, cognitive behavior therapy is a collaborative approach where you learn to identify those common negative beliefs and behaviors, because we also engage in pretty self-destructive behaviors, that are disruptive to our lives. And first you have to notice them, learn about them, and then, thanks to Dr. Maki explaining to us that we have neuroplasticity, we can actually change how we think about things, really alter those beliefs and thoughts and the behaviors that go with them. And sometimes we have to, it depends on which direction we go first. Sometimes, and we see from the slide here, it's not always that it's always in the same direction. Sometimes we alter the behaviors to help us change our beliefs and our thoughts. And sometimes we can change our thoughts, which will then engage us in better behaviors. So prime example for, say, activation, because behavioral activation is part of this, is exercise. And look, I exercise almost every day. I don't like it. I don't want to. I have no intrinsic motivation to do that. And so if I waited for the actual interest and motivation, that would never show up. So I know better, right? And so now I go to the gym, I put on my workout clothes, I get on the treadmill, and only then does a smile come on my face, and I think, oh, this feels good. But if I had waited for the thought to get me there, it wouldn't happen. And so, but I've now done something that really will benefit my mood, because it actually does. And so in the other direction, though, as we said, activating and doing things that we enjoy can really be helpful. Think about what depression is. By definition, it is anhedonia, the loss of interest in things that bring you pleasure, and avolition, the loss of motivation to do things that are rewarding. When we get depressed, right, we lose energy, we get flat. Depression isn't sad. Depression isn't necessarily tearful. Depression is flat. We lose any sense of what's meaningful in our lives, and that's really depressing. And so we need the cognitions to change, to be able to alter that, to recognize them as dysfunctional and not accurate. And we need the behaviors back in place, because you'll say, oh, come on, play golf with me. I know you love golf. No, I don't feel like it. But if you get them out there, or if they know that that's their homework assignment, then they're like, oh, you know what, that was actually pretty good. And that reinforcement helps with the mood. So it goes in all three directions to alter the cognitions and to alter the behaviors.
And I'm glad that you talked about exercise, because we were just about to segue into medications, but before we get there, these natural things that we can utilize to support us are so important, and sometimes we forget them. Things like what we eat. Certain foods feed our brain so that our neurons, our brain cells can work better, so that we have less anxiety and depression, less sleep issues. Certain things like, getting rid of that pesky light in the room. I've been traveling a lot, but I call myself the light hunter. When I go to hotel rooms, I'm searching for the light, and I have a tape to cover it up, because there are things that are within our power and our control that we can do from a lifestyle standpoint. Getting rid of toxic habits like smoking, excessive drinking, and toxic people. Those are all lifestyle things that we can utilize to support us. But we will segue to medications, because some of us will need medication support, and that's okay. All of us won't, and we want to cover that. So Dr. Kingsberg, when do you think it's the right time to start exploring medication?
Well, I think, a lot of times people get sent to me by their physician often, and they'll say, does my patient need medicine, or do they just need cognitive behavior therapy? And for example, with postpartum depression or with a serious depression, sometimes I want them started sooner than later to kind of kickstart the shift. Because when I think about what an antidepressant does in combination with cognitive behavior therapy, is it turns down the volume on the rumination, on those what-ifs. And it gives the brain a chance, as you put it, to get that prefrontal lobe kind of connected, so that they now have a chance to turn the volume down to say, do I really think that? Because they are so automatic. Those thoughts and those ruminations are so automatic, you don't get it, you're just bombarded with them. And so it gives me a chance to do my best cognitive behavior therapy when I can help them turn down the volume. And sometimes medicine really does that. Now, I have many women who'll say, I'd really like to not do medicine first, and I'm willing to start them there. But if I really see them sort of sinking into not being able to engage with me or do some of these behavioral things I want, I'll say, you know what, I really think that medicine is for you.
I found the same thing in my practice, and sometimes people have histories of trauma, right? And so they're constantly in fight or flight, or other times there's an undiagnosed ADHD, so we have to address that with stimulants. And not everyone can jump into cognitive behavioral therapy. It's great, but some people need support beforehand, because there's homework. It's hard work. The saying, do the work. There's work involved, but the work pays off. And Dr. Maki, what do we know about the most effective treatment for depression during the menopause transition?
So if we take this idea that the people who are most vulnerable to major depression, so this is clinical depression, the sad news is we're all vulnerable to an increase in depressive thoughts and symptoms. That might not make that mark of clinical depression, but they affect our lives, right? If we're feeling a little less interested in things, even if we're not in major depression, it still affects our quality of life, right? That's not what we want the antidepressants for. So we're talking about clinical depression. And for those depressive symptoms that don't meet the criteria for major depression, we want to engage in the exercise. We want to refrain from having that second glass of wine, right? Because the effect the next day, especially if you're estrogen deprived, is even worse on your mood. So it feels better in the moment, but we also have to avoid that, right? And friends trigger dopamine. That's why we're always looking at our phones. Our friends make us feel pleasure. So we want to engage socially with people. How many of us have felt down and your friends are like, do you want to go do something? And you're like, no, I'm really not. But then you do it anyway. Do you regret it? No, right? That's part of that behavioral activation. Okay, so I just want to distinguish between elevated depressive symptoms, where you want to use those behaviors, and major depression when we're thinking about medications. So if we go only to the randomized trial data, there are 2 large randomized trials of antidepressants. Venlafaxine works. But then there are 10, 20 additional trials that show that basically they all work at this point in time. It's just that venlafaxine has the most data to back it up based on clinical trials. And sometimes you want to pair that with a hormone therapy. So if you're chronically sleep deprived because of hot flashes and nighttime awakenings, you want to pair the antidepressant with a hormone therapy so that you have both of those causal arrows, if you will, into your depression taken care of. Antidepressants might take away 1 or 2 of your hot flashes. That's all it does when you measure those hot flashes objectively. They don't really take away a lot of hot flashes. They take away 1 or 2. So you need to treat that as well, right? So you have to think about, am I depressed? Is it more of a neurochemical thing? Is it more of a serotonergic thing? In which case I might want an antidepressant. Or is it also my menopausal symptoms? And then you need to treat that as well. Okay, so both arrows are important. And then I think CBT, all of us should have it. Honestly, we all have negative thoughts. I think everybody should have some type of therapy at some point in their lives for that. So those are the major treatments for depression. And again, it's the love the one you're with, right? Use whatever you used in the past. And then think about adding on a hormone therapy if you have those menopausal symptoms. The reason that's important is that studies have shown that if you monitor women and you measure their mood, that my hot flashes on Monday predict my mood on Tuesday. So it triggers over time in that way. It's not the opposite, interestingly. The studies haven't supported that. So we need to prevent those depressive symptoms by getting good sleep and treating those vasomotor symptoms if they're moderate to severe as well.
I'm glad you brought up sleep because we talked about hormones, right?
Yeah.
We talked about antidepressants. What are some of the options to support us when we're having sleep issues?
Gold standard, according to the American Academy of Sleep Medicine, is CBTI, cognitive behavioral therapy for insomnia. Do you withdraw from that? Once you know how to stop those negative thoughts, you use those practices again and again and again. Once you're off of a sleep medication, do you get the benefit from that sleep medication? No. And that sleep medication doesn't restore sleep as we know it. It makes you sleep, but it doesn't create the same stages of sleep. The architecture of sleep is not the same on sleep medicines. I think they have a role for bereavement, right? When we just have to get sleep and it's this biological instantiation of grief or some major stressor to help us through, but it's not a long-term solution. And another really important tool in our armamentarium for sleep in mood is taking your progestin at night. So we have this receptor called GABA, and it inhibits our brain functioning. It quiesces them. And that's what benzos work on. They work on that receptor. They decrease the activity in your brain. And that's exactly what progesterone does. It works on that same receptor. So that's a powerful tool if you take it at night. It can help you to kind of relax and be calm.
And you mentioned GABA, and there is a medication called gabapentin. There's trazodone. What are those some good options for people to consider?
What's your clinical experience with those?
If you don't, I find them very sedating. So it would not be my first choice.
Mm-hmm. Too much GABA.
Great. And the other thing is that, you're right, some of these medications cause withdrawal, so there are risks associated with it, and you should know about that before.
Right.
CBTI you can get online, so you don't necessarily have to find the right practitioner right in your city. You can actually, there are some good websites, which please don't ask me right now because I'm going to have a blank moment, but there are very good CBTI programs online, so they have already been established.
Dr. Kingsberg actually just practiced a skill right there. That's a CBT skill that she just did, right? She said, I'm having a moment, I'm forgetting a word, and she just said it, right? Did any of you think twice about that? No. What happens is, if you actually go and you say, oh my God, I'm forgetting the word, you get really distressed about it, I think I have Alzheimer's disease, I think, what's wrong with me, right? So the more you fight that, the worse the symptom is. So she actually just did CBT on herself in that moment. Same thing when you're having a hot flash,
Do you think
right?
I
If
have
you
Alzheimer's?
say, what's that?
Do you think I have Alzheimer's?
I do not think you have, no, that's a catastrophic thought, right? And so then the other thing is, and I'm a therapist too, I'm a CBT therapist, you can tell. The other thing is, the same thing with a hot flash. I'm having a hot flash right now, right? You're at work, instead of fighting it and being embarrassed about it and being like, oh my God, I'm having a hot flash, I have to hide it, right? What am I gonna do? I'm so embarrassed. I'm having a hot flash right now, right? People are less likely to judge you when you actually say that than they are when you're actually trying to hide it. So those are like some practical skills. I'm just saying that because I'm a therapist and I needed to put that in there. But we're gonna take some questions and answers now, I think. So who wants to start? Who has a question about mental health?
Or who doesn't have a question about mental health?
I know you mentioned it briefly, but can you say more about sleep, if you have trouble falling asleep versus if you wake up during the night? I typically, if I wake up, it's because I have to go to the bathroom. I can go to the bathroom and go right to sleep. It's the falling asleep part that trips me up. Are there different mechanisms or different ways we can think about trying to address that?
Well, first of all, there's sleep hygiene. So you need to make sure that your bedroom is used for sleep and sex.
Sex.
I was not going to forget sex. Sleep and sex. And as the dark, what did you call
Oh, the light hunter?
the light hunter, you need to make sure that it's dark and cool. And then there is the mind issue, right? Like I said, oftentimes as soon as it gets dark and quiet, then all the voices come in. Not auditory hallucinations. These are the thoughts of what do I need to do, what happened today. It is the past and the future. And really a mindfulness approach to good sleep and falling asleep is to stay present because the background noise of what happened and what goes forward is going to keep you spinning. And that is, if you need some help with that, I really do think putting it on paper, giving yourself no more than 10 minutes, usually 5, to dump down on paper, and it's actually helpful if you write it, not type it, because you don't want the blue screen stuff anyway. Write it out, and you can say what you were obsessed about of what happened to you today, or what you're worried about tomorrow. It really can sort of cleanse you. We wash our face, we brush our teeth, we floss, but we don't often dump all of that stuff that's in our heads, and that can be really, really helpful. If you can't fall asleep within 20 minutes, you need to get up, do something else, take a break, because if you sit there watching the clock, that is a terrible thing to do. That will just get that all started all over again. And then there is Wordle.
And we also have to train our brains that it's time to sleep. So we have these circadian rhythms where our bodies get used to and predict and know that something's going to be happening, this is my rest time. So a really important part of sleep hygiene is trying to go to bed at the same time every night, regardless of whether it's a weekend, because your body learns it's bedtime. There is a learning mechanism, and just building that habit is very important. And that can help us to fall asleep because it's like, okay, your body says, oh, this is the time that I fall asleep.
Yep.
And also creating a sleep cubby, a sleep haven. Some of us, if we invest in like really nice pajamas, soft sheets, things that make us look forward to sleep so it's an experience and not just something to do, that also trains our brains to acknowledge sleep as being so sacred, because it really is.
I need new jammies.
Who else has a question? have anyone over there? Oh.
So I just recently started taking hormone therapy, and I'm having an effect. I don't know if this is common or if it's maybe not related at all, but the progesterone actually wakes me. So I wasn't necessarily having sleep issues, and then I started having sleep issues with the progesterone.
How do you know it's the progesterone and not the estrogen?
Well, because I know I'm not supposed to, but I was just going crazy because I couldn't sleep. So I didn't take my patch off, but I did stop taking the progesterone for 2 days. It was also giving me crazy anxiety.
Yep.
So that's
Yeah.
my unscientific.
Yeah, so how many of us have tried an oral contraceptive at an earlier point in our life and we become, what's the pleasant word? Irritable, right? And then you switch to a different progestin and you don't have that effect. Yeah, sometimes these are class effects. Sometimes it depends on what your progestin is, and we can find that we can switch that. Not to get too technical, but it actually changes how the GABA receptor works, what's influencing its modulation, so different progestins. So you can try a different progestin, and some of us are just sensitive to them, and really, if we're sensitive to progestins, then we can do a vaginal progestin instead. Right, that's a really good option because then our brains never see it, if you will. So you might try that. If you find that you're sensitive to a progestin, you may change the route of administration and try to do a vaginal progesterone and see whether that's a good option for you. Yeah.
First, thanks for all of your information. I've been dealing with insomnia for many years, and I've used a lot of the suggestions that you have said. And I also take magnesium at night, which I find helps. I wake up at night and I don't necessarily have anxiety if I take magnesium. I'm just simply awake. Like, my body thinks it's time to get up multiple times a night. It's just, oh, let's get up. It's morning. Does that mean it's not hormonal? What does that mean specifically when you're just awake without anxiety?
I don't know that we can attribute a specific sleep episode, whether it's an awakening, to one particular neurobiological source in that manner. But what we do know is that we can have those awakenings after sleep onset without the anxiety, and it's still a menopause symptom. In other words, not everyone does that. And that can happen after CBT, right? We can decrease those negative thoughts, but it doesn't necessarily mean that we don't have those wake episodes. It's just that rumination keeps us awake for a little bit longer. So if those sleep episodes are common and you feel energized, the guidance is to get up out of your bed, go to another place so that your brain learns that my bedroom is my sleep space. So there's some ideas about the importance of sleep hygiene with respect to these episodes. So if you know that when you wake up, it's going to be a good half hour, some sleep experts will recommend to you that you actually move yourself physically from that room so that you can go back to this sleep place when you're not so energized.
And also one of the things I've done with my clients who have a hard time with sleep and we can't figure it out, I ask them to start keeping a journal about what they're eating during the day, what they're doing during the day. And that can sometimes help you because in some cases, some of my patients are taking supplements or things that they didn't know had caffeine in them, and that was contributing to the sleep issues. And then and also it gives you a sense of empowerment because you're actually doing something and you're bringing information to the doctors. And if we still have a hard time, then I work with sleep medicine colleagues because there may be something else going on and they may need a sleep study or they may need help with sleep apnea because, not everyone who looks like they should have sleep apnea has it, and some people who look like they shouldn't have it. So we just want to be sure that we're covering everything.
Wait, so we have a question from our online community. So the question is, can OCD symptoms increase during perimenopause in women who have struggled with these symptoms in the past?
Yes.
Yes? Absolutely. Because, again, you could have anxiety symptoms, you can have depressive symptoms. And just like Dr. Maki said, if you have a history of depression, then it's going to be an increased risk at menopause. perimenopause, and the same thing for OCD symptoms. They follow in that same brain chemistry pathway, and it's the same thing for postpartum depression. If women are prone to anxiety, they're going to very much have anxious symptoms during postpartum. It's, what if I hurt my baby? What if I forget my baby? What if? And they are very anxious, catastrophic thoughts. And so that OCD checking and worrying, and especially if you're worried about your memory now, it will tend to increase that anxiety about checking. So it's a double whammy.
Yeah, and we've talked about depression and anxiety because they're the most common conditions. But schizophrenia changes. At menopause, we published some work on that. Manic depression does. And again, it's because the female brain doesn't like this variability. And our emotional regulation neurocircuitry, our prefrontal cortex, putting the brakes on the amygdala, is part of many different mental health conditions. It's not just unique to depression and anxiety. So any woman entering the perimenopause with a history of one of these psychiatric conditions really can help herself by having a conversation with her provider as she's entering it and saying, I understand this is a period where I really need to make sure I don't have a lot of fluctuations in my hormones for that reason. These neurobiological circuits overlap. The depression circuitry overlaps with the schizophrenia circuitry. The anxiety is part of OCD. So it's all of a piece, right? So we don't want to get too focused on what we call taxonomy, on categories of mental health disorders. This is a general period of flux for the brain. So that means that a lot of different mental health conditions and symptoms will be affected.
ADHD, PTSD,
Yes.
all of these things, it's helpful to know your history. With my patients, we do a tree, so we look at the family tree and we draw it on the branches, your life experiences. There's something called ACEs, right? Adverse childhood events. But with adults, when we have adverse events, that impacts our outcomes as well. So we want to think about all of these things so that we can best predict what will happen to us. The same way that I do with my patients who are about to be expecting a child, my patients who have schizophrenia, who have bipolar, who have a history of PTSD, we talk about what to expect as they approach perimenopause and menopause.
We have time for one more question.
I talk with a lot of women who are just trying to figure out, am I in perimenopause? Is this happening to me? What's real? But the thing that I'm finding most interesting, and I'd love to hear your thoughts on, is so often the response I get from women is fundamentally, I'm not allowed to have needs. So therefore, that's great that there are people out there doing this perimenopause work and that are helping, but I'm not allowed to need that kind of help. How do you start to address that, and how do we in this room start to address that pervasive?
Amen. So let's talk about how do we know when we're in perimenopause. So the gold standard criteria are something called straw plus 10. You don't need to know that. You don't need a test to tell you if you're in perimenopause either. You don't need to spend any cash on that, unless you have an endometrial ablation or a hysterectomy. But let's say for most of us who don't have that, your menstrual periods change in the perimenopause in fundamental ways. So as we go from our reproductive years to our late reproductive years, whatever our cycles were, that was normal. Let's say we bled heavily on day 1 and then kind of tapered off. When that changes, you're still premenopausal, but you're in something called the late reproductive period. And that tells us whatever was normal for me with respect to my menstrual cycles is changing, okay? When you enter the perimenopause is when your menstrual cycles become less predictable in terms of their timing. So let's say you got your period every 28 days. And then suddenly the next period comes 35 days later, and then the next one 17 days later. The regularity of your menstrual cycles change, and that's when you're in the early perimenopause, okay? When you start to skip cycles, I went a whole month without my period. That's when you're in the late perimenopause, okay? And then when you go 12 months without a menstrual period, you back it up to the day after that last menstrual period, and that's the day you became postmenopausal. You don't know for 12 months, and then it goes backward in time. okay? So that's how you know. Now, you may need tests if for some reason your menstrual cycles aren't regular for a variety of reasons. You're on a long-acting contraceptive, or some medication that you're on is affecting your cycles, or you have PCOS, or you've had a hysterectomy. Then you might need a blood test to tell you whether your FSH levels some way or your AMH levels is another way. But that's how you know. It's simply knowing what your periods are like and changing them. That's how we know if we're perimenopausal or not. Now, this idea that I can't have anything about me, yeah, that's a sex role that we all have, right? I actually like to say to my daughter, I have a 15-year-old, the universe sent me the child I needed. She's this laid back, hoodie girl, you know, she's just the thank you, universe, for sending my daughter to me. And when she went through puberty, she'd apologize. That's how good of a kid she is. She'd say, oh, I'm so sorry, Mom, my prefrontal cortex isn't working well. She would, because she's my kid. And I said, you know what, sweetie? I don't ever want you to apologize to me for being irritable when you have your period. I want you to just say, I've got my period, I'm irritable, that's it. Like, do men apologize for being hangry? Oh, excuse me, darling. I'm hormonal right now. I'm a little irritable. You know, it just doesn't happen. So I think part of this is that we need to own and label and say, yeah, I'm going to be a little irritable right now. I'm in perimenopause. Now, there is something you can do about that irritability, which is to level out the hormones. And we saw that in a beautiful study out of UNC. But I think we have to bond together and say we're not going to just suffer through this thing together. We're going to talk about it. We're going to look for solutions, and that's the whole point of today, isn't it? We're going to normalize it, but I don't want women to always apologize for what happens to them hormonally either. Go ahead, label it. Take responsibility for it if you're, unkind, but try to be kind to yourself and recognize, I'm going through something. This is biology,
Thank you. Thank you, Dr. Maki. That was a great way to end it. Validate the mind-body connection, and I hope that you all learned something wonderful today.
It's a great panel.